set of proteins across multiple species. And we also know that across multiple species, there are declines in motor performance that can be very, very easily measured. So whether you're looking in the Drosophila, this is data from Mark Miller, or you're looking in rodents, this is data from Christy Carter when she was at the University of Florida. Depending on whether you look at sort of wing muscle performance or in the rodents, this is a summary performance score of several different tasks, including treadmill running, the rotorod, and grip strength. You can see that higher levels of motor performance, higher levels of physical performance is synonymous with greater survival and reduced mortality. And this same thing is true in humans. This is a large pooled meta-analysis that was done in over 20,000 older men and women by Stephanie Studensky, showing that there is a very close association between habitual walking speed or gait speed. These are data in both males and females, and median survival. And this persisted regardless of the age that the gait speed was assessed. So survival is linked to walking speed in humans, and it also seems to be linked to measures of motor function in other animal models as well. So this suggests to me that, at least in part, there's some biological basis, I think, for these age-related changes in muscle and motor function that occur. We've also looked at cellular senescence in some large cohort studies now. These are data that we analyzed from the Lifestyle Interventions for Elders trial, which I'll talk about a little bit later. These are data from 1,377 males and females. Mean age was about 79 years. They were all pre-frail or frail. And we looked at a panel of senescence factors in the plasma. These were all analyzed by my collaborator, Nathan Lebrasser at the Mayo Clinic. And we were able to show very nicely that there is a profile of senescence factors that is related both to muscle strength in these older individuals. Some of the more strongly associated ones were activin A, GDF15, RAGE, MMP7, and TNFR2. And they were also related to this summary short physical performance battery score here. So much so that when we used gradient boost modeling, which is a sophisticated machine learning-based statistical approach. When we looked at the top 10 senescence biomarkers and looked at their ability to predict poor physical performance in this cohort, they were highly sensitive and highly specific. So the area under the curve was very close to 1.0 here when we looked at this model of all the top 10 biomarkers with some known covariates of physical functioning: age, sex, race, and BMI. And even the top 10 senescence biomarkers alone were highly sensitive and specific for assessing individuals that had a low physical performance score. Again, I think reinforcing that even in humans, there is probably an underlying biological basis for these changes in physical performance and muscle functioning. Now, despite the increased mobility, disability, and awareness of and these problems in older adults, I think when we look clinically, there still is not much clinical awareness of sarcopenia as a syndrome. This was a survey that was done that was led by Jack Goralnik in the United States, looking at different healthcare practitioners and whether they were familiar with the term sarcopenia. So the question that we asked was, how familiar are you with the term sarcopenia? And we looked at that in related to different specialties in medicine. And you can see here the dark area here are people that reported that they were very familiar. A little bit lighter is somewhat familiar. Not familiar was the light green here, and the lightest green here was not familiar at all. So you can see the distribution of familiarity with sarcopenia, with the term sarcopenia, among individuals that were in internal medicine practitioners here. You can see that many were heard about it, but not very familiar or not familiar at all. Similar findings in individuals that were family medicine practitioners here. Do a little bit better in geriatrics, as we would hope. Most of those people were very familiar with sarcopenia, but still a small number that were not familiar at all. And do a little bit better here in the specialties of physical medicine and rehabilitation. So in addition to understanding sarcopenia as a syndrome, and we'll talk about that, I think we have to do a much better job about even educating clinicians about awareness of sarcopenia and really how important this syndrome is for older adults. And we also have to do that with our patients, with older adults. I think older people, this is my quote here, but I believe this. I think older people in general don't understand that when they have trouble climbing stairs or walking, that they have a problem with their muscles or their muscle functioning, or they have sarcopenia. So I think we have to do a much better job about awareness among clinicians and awareness of sarcopenia among patients. It was interesting, I thought, to notice that shortly before Queen Elizabeth died, there was increasing reports of her struggling with mobility in her advanced years. And in fact, she had to miss several important meetings and gatherings because she was struggling with issues related to getting around and with her mobility. And I think her physicians prior to her death were primarily concerned with her reduced mobility. And this was interesting to me because it was one of the few times where we heard in the press about someone struggling with mobility functions rather than some specific disease that led up to their death. Now, this is how we think about sarcopenia now. This is really the age-related decline in muscle mass and function. These are CT images from some research participants in our laboratory. This is the mid-thigh area. So just to orient you, this is the front of the thigh here. This is the rear of the thigh. So these are the knee extensor muscles. These are the knee flexor muscles. And this small white area here is the femur, or the large long bone of the leg. And you can see, even without knowing how we digitize these images, there's a dramatic change in the area that's occupied by muscle here when we look at someone who's 43 years old compared to someone who's 76 years old. And I think we're all in the community now generally in agreement that sarcopenia is really a syndrome that's characterized by progressive generalized loss of skeletal muscle mass and strength, with the risk of adverse outcomes such as physical disability, poor quality of life, and death. A few years ago now, the coding group that codes medical diagnoses actually established a separate and independent code for sarcopenia. So this can be diagnosed clinically. There is an ICD-10 code for sarcopenia. And I think most of us agree now that the components of sarcopenia are really related to changes in muscle mass, muscle strength, and the resulting impact that those changes have on measures of physical performance. And I'll talk a little bit about these components in a minute. There is generally consensus around the world. There have been several groups that have been working and continue to work on coming up with some universally agreed upon definitions of how we sort of classify individuals who are sarcopenia. And this is the list of those. A couple were based in the United States, and one large group was based in Europe. I think we've known about muscle loss with aging since early in the history of the world. Certainly, it's reported on in the Middle Ages and in Shakespeare and other works. But some of the first modern era documentation of age-related declines in muscle mass come from data from the Los Alamos National Laboratories in the United States. And this is the nuclear testing facility in Albuquerque, New Mexico, or Los Alamos, New Mexico. They simply looked at total body potassium concentration by measuring radioactive potassium-40 in the body. Remember that potassium is largely an intracellular ion, so that if you have a technique that can measure total body potassium, it's really giving you a measure of total body cell mass and really a measure of total body muscle mass here. And you can see that in both females and males, muscle mass rises during growth and development and then begins to decline, at least in this case, probably after the age of 20 years, maybe 30 years. And you can see a limited number of data here, but this well-described age-related decline in total body potassium, which is synonymous with declines in muscle mass. This is data from the Baltimore longitudinal study of aging, showing a similar thing. This is a 25% loss in muscle cross-sectional area of the lower leg, starting at age 20 and following individuals up to age 85. Interestingly enough, if you look at the amount of force generation that muscle can generate over the same period of time, you see that with muscle mass, there's about a 0.5% decline in muscle mass per year. The declines in muscle strength or force generating capacity are actually twice that. So there's about a 1% per year decline in muscle strength or muscle force generating capacity, so that by age 85, an individual has lost about 50% of the strength that they could generate at age 20. Just to go over a couple of the most common techniques that have been used to assess muscle mass in both population or epidemiological studies and also in intervention trials. The three that have been largely used have been dual energy X-ray absorptiometry or DEXA, computed tomography scans or CT, and magnetic resonance imaging scans or MRI. DEXA has been widely used because these scanners are widely available. They were first developed to measure bone mineral density and really were developed with the advent of cut points and objective measures for defining osteoporosis, and also the development of a number of treatments for osteoporosis. So DEXA scans have been used widely for a number of years. They're based on the attenuation of a small, low-dose radioactive scan source that is attenuated across bone mineral-free lean tissue. They have very high precision, 1 to 4%. Again, the radiation exposure from DEXA is extremely small, less than 1 millirem, equivalent to about 3 days of background radiation. And these machines are widely available, as I mentioned. There are two major manufacturers of DEXA scanners, and so there are some analytical differences across manufacturers and models, so that if you're using these in clinical trials or multi-site clinical trials, there's some standardization that has to take place. But those problems are generally easily addressed. Computed tomography, as I showed you previously, can measure the cross-sectional area of muscle and also some other interesting features of muscle, as well as measuring the regional fat deposition or regional adiposity as well. So CT actually does measure a direct physical property of the muscle, its cross-sectional area. It has very high precision, very reliable. Precision is about 1 to 3%. You can also look at the density of the muscle area and get some estimates of intramyocellular lipid accumulation, and also look at the deposition of adipocytes between the muscle fibers and under the skin as well. The drawback here is that there is much more radiation exposure that's necessary for the CT scans, about 15 millirems per image, but that is still within acceptable ranges. And we have used CT extensively in many of our observational and clinical trials. If we want to get more sophisticated, there is also ability to measure muscle cross-sectional area using magnetic resonance imaging. The principles of measurement are similar. The precision is also very high. And these measures agree very well with CT measures. The advantage here is that there's no radiation exposure. There are some additional small technical complications to deal with the MRI images, but those are not insurmountable. And because there's no radiation exposure, you do have the ability to acquire multiple slices across body regions, and you can do this. And actually, there are well-established algorithms to reconstruct three-dimensional volume estimates. So in addition to looking at the cross-sectional area of various muscle segments or muscle groups, you can actually measure the volume of those muscle groups. And there's some suggestion that might allow better precision and maybe more sensitive to change with interventions. Although I think I'm not completely sold on that idea, but there is that ability. The drawback here is that there is a higher cost, and of course, to acquire these scans, the people have to sit very, very quietly and carefully in the scanner while the images are being obtained. So if someone moves, it's a problem. Those things don't happen with the CT scans because the images are acquired very, very quickly, much like an X-ray is acquired. There are also newer techniques that have been developed that are still being validated and evaluated. One of those that is fairly exciting is this isotope dilution technique using deuterium-labeled creatine. Creatine is a compound that is largely found intracellularly in skeletal muscle. So by measuring the dilution of a stable isotope of creatine, you can get an estimate of total body muscle mass. This is simply done by ingesting a capsule that has labeled creatine in it. That creatine is absorbed and diluted throughout the body. And because all of the body creatinine is converted into creatinine and excreted in the urine, you can simply measure the urinary isotopic dilution of creatinine and get an estimate of total body skeletal muscle mass. And in fact, in some large epidemiological studies that have been done looking at total muscle mass by D3 creatine dilution, investigators have been able to show that strongly predicts several measures of mobility limitation and mobility disability. And actually, it predicts that better than lean mass measured by dual energy X-ray absorptiometry. So these are the predictions and the odds ratios using the D3 creatine method here, which shows a strong association from the highest to the lowest quartile of creatine, of muscle mass by creatine here, with prevalent mobility limitations, difficulty bathing, difficulty getting up out of a chair, difficulty lifting, and difficulty with heavy housework, compared to those relationships using measuring lean mass by dual energy X-ray absorptiometry. And I think that really does point to the fact that these techniques are probably measuring different components of the lean body mass here in the body, where DEX is measuring total lean body mass here. It's measuring muscle, but it's measuring other residual soft tissues here, whereas the D3 creatine dilution is in principle measuring only exclusively muscle mass. I think we have to learn a lot more about this technique, but it's certainly an exciting technique from the standpoint of having better, more direct approaches to measuring whole body muscle mass as well. When we think of muscle strength, there are several measures to measure muscle performance. We can measure strength using measuring the maximal capacity to generate force or tension. In large cohort studies, this is measured using grip strength. We can also measure this using weight machines. We can also measure muscle power, which is a little bit different measure, which looks at the amount of strength that's generated, but also has a time variable here. So it's the rate of work being produced. We can look at muscle fatigue, which is the inability to maintain a given force output. Sorry about that. And we can also measure muscle endurance which is the submaximal aerobic exercise time to exhaustion. These different measures of muscle performance are all overlapping, but I would argue that they measure very distinct physiological properties of skeletal muscle. And I think when we've tried to develop interventions for sarcopenia and interventions for improving muscle function, sometimes this has been challenging. What are we really trying to intervene on, and how are we going to develop therapies, and what are they specifically targeting? And this is important, I think, when we're thinking about preclinical models for muscle function and how those results from some of those preclinical studies translate into clinical trials in this area as well. There are also very well described measures of physical functioning that are important components when we're looking at sarcopenia related to mobility. Some are related to measuring walking capacity, like the 400-meter walk test, the 6-minute walk test, or more composite measures of physical functioning, like the short physical performance battery score, which I mentioned previously. There are also good tests to measure stair climbing performance. These are all measures of capacity or performance-based measures of physical functioning, but there are also well-validated self-reported instruments or questionnaires that can ascertain these functional measures as well. And I would argue that clinical trials in sarcopenia need to target clinically meaningful differences in physical functioning. It's really not enough to know whether someone's strength or muscle mass is improved by a therapy, but we also really need to know whether these measures are improving their physical functioning. And I believe that measures of physical function really serve as important biomarkers of this syndrome that we think about as mobility disability. Just very, very briefly, I want to touch on the idea that there has been an evolution of how we think about sarcopenia. So there's been an evolution of the definitions that we use to ascribe to sarcopenia. Many of these were initially based on expert consensus. All have included objective measures of muscle mass or lean mass. And I showed you a little bit about some of the controversy about that, looking at lean mass by DEXA versus some of these newer techniques. All have incorporated muscle weakness or reduced physical functioning into the definition. There have been limited efforts in the past to evaluate components of sarcopenia, or some of these components of sarcopenia, with respect to clinically meaningful distal outcomes like falls, fractures, or mortality. Are these changes that we observe in older people, are they really linked to bad distal clinical outcomes, whether it's increased likelihood of falls, fractures, or mortality? But there has been really excellent progress. A couple of initiatives, this work by the Foundation for NIH, the Sarcopenia Definitions and Outcomes Consortium, and a group in Europe that's tried to ascribe some objective-based measures to sarcopenia, have made excellent progress towards definitions I think that all of us are a little bit more happy with now, and also the appropriate regulatory agencies and scientific societies are happy with. And just to show you this, if we look at some of the sort of timeline for this, these were some of the early sort of evidence-based definitions of sarcopenia that started appearing early in 2010, early in 2011. This is the European Working Group definition. I led this group, this international working group on sarcopenia that sort of came out shortly after the European Working Group. These were largely, opinion-based expert consensus, and as time has progressed here over the last 20 years, more groups have tried to incorporate a more evidence-based approach towards defining sarcopenia. So much so that, I just want to skip over a couple of these slides, but so much so that the Sarcopenia Definitions and Outcomes Consortium have really looked at several different measures using classification tree regression analysis in a large cohort of older adults, showing that muscle strength is really a strong predictor of bad distal clinical outcomes. This is looking at muscle strength by grip strength either in individuals that had weakness and slow walking speed or weakness alone, showing that both weakness and slow walking speed really was associated with bad clinical outcomes. This is falls here, hazard ratios for falls, mobility limitations, mortality, and fractures, showing in many cases that being slow and having muscle weakness was associated with an increased odds ratio of having hip fracture or mortality. And so our conclusions from this analysis really were that both weakness, defined by low grip strength, and slowness, defined by low usual gait speed, should be included in an objective definition of sarcopenia. In the analysis that was done as part of this consortium, we really could not find any association between low lean mass, at least measured by, again, dual energy X-ray absorptiometry, and hard clinically meaningful endpoints. So we didn't think at this time that it could be included in a definition of sarcopenia. There has been more endorsement of this definition by other groups, and I think we're approaching a point where there's harmonization in some of these cut points, even by our European colleagues. This was their sort of evidence-based sort of scheme for defining sarcopenia in older populations that came out in 2019. But when you look at the cut points that they proposed here, they are actually, in fact, fairly similar to the objective cut points that we proposed in the SDOC criteria here. The SDOC criteria are here, and the European Working Group cut points are here and here. So we're actually approaching some harmonization of the low grip strength cut points across different groups here. And I'm involved right now with an organization that's trying to come up with an international consensus on how to define and operationalize these definitions of sarcopenia. There's much more agreement about what defines slow walking speed. Most groups now agree that older adults that are walking at a gait speed of less than 0.8 meters per second are at risk here, and there's general consensus about this as well. So we are getting nearer to a universal definition of sarcopenia, but I do think there's still some work to be done. When we think about therapeutic interventions for sarcopenia, we think about lifestyle interventions. These have focused largely on exercise and physical activity interventions, and I'll show you some of the data around this, but also there has been some work done on nutritional and nutritional supplement interventions related to protein intake, vitamin D, and omega-3 fatty acids. There's also a lot of exciting work focused on the gut microbiome right now and sarcopenia. I don't have any data to show you, but there's some evidence that that can also be influenced by some dietary factors and may have some effects on muscle as well. And then there are a host of pharmacological interventions that are in development by large and small biotech and pharma companies. These are largely, some of the initial ones were really related to the selective androgen receptor modulators, or the SARMs, both the steroidal and non-steroidal SARMs, but more recently, targets addressing or targeting myostatin, either monoclonal antibodies or receptor ligand traps. Myostatin is a negative regulator of skeletal muscle growth. So these targets have either tried to neutralize myostatin's effects with neutralizing antibodies or block the actions of their receptors. There are also more novel targets related to targeting neuromuscular function, such as the skeletal troponin activators of mitochondrial biogenesis, which I think is a really interesting area, either by activating the sirtuin pathways or stabilizing mitochondrial mitophagy pathways. And also interest in looking at medicines and dietary supplements that have been approved or marketed for other indications. And even in individuals, I think, that are interested in exercise or nutrition and rehabilitation, some of these agents, I think, may develop indications that are going to be in conjunction with other therapies, such as rehabilitation after injury, surgery, or fracture. So I think now, even though these compounds are in development, I think they are going to be the future. And I think even folks that are interested in exercise and physical therapy for sarcopenia are going to need to know about these, because it's going to probably be not only exercise or nutritional interventions, but also combination therapies where we may have pharmacologic agents on board as well. Just to show you some of the effects that exercise works, this was a study that we did here at Tufts a number of years ago now in fairly healthy postmenopausal women. So these were individuals that were randomized to high intensity progressive resistance training, strength training exercise for 1 year, twice a week. One group got exercise twice a week, and another group was an attention control group, and they got health education once a week for that 1 year period. And you can see very nicely that the individuals that were randomized to the control group lost lean mass. This is again by DEXA here. And those individuals that were randomized to the exercise group had about a 1 kilogram increase in their total body lean mass. So the change in lean mass from control to the exercise group was about 1.5 kilograms. This was also met with corresponding increases in the maximal muscle strength of several different muscle groups that you can see here on the left. And this is the percent change in muscle strength. So in healthy postmenopausal women, strength training exercise at least works. We also know that in men and women who have some mobility limitations, we can also improve not only their strength and their muscle power here. This is data we did more recently in our lab, but we can also look at improvements in their muscle fatigue capability. So this is their ability to resist declines in muscle force. So this is the group here that got health education control. This is baseline in gray, superimposed post-training here in dark. No real change on their fatigability of their muscle. This is 120 contractions repeated over 2 minutes. You can see that their ability to generate force declines here, no change with training. But in the group that got 4 months of progressive resistance training here, again, strength training exercise, you can see that their ability to resist and delay muscle fatigue here is improved significantly. So we can improve muscle power, we can delay fatigue. And then when we did the large phase 3 randomized trial looking at exercise in individuals with mobility limitations. This is 1,600 individuals randomized across 8 clinical centers. They were followed on average for almost 3 years. One group was randomized to a combined aerobic plus resistance exercise training intervention. The other group got a supervised health education program over the same period of time. And when we looked at the onset of major mobility disability in these individuals, this was defined as the development of the inability to walk 400 meters. So all of these individuals at baseline were able to complete a 400-meter walk, and they had the outcome. They became or were defined as being mobility disabled once they were no longer able to complete the 400-meter walk test. You can see that many more people randomized to the health education group actually developed mobility disability, developed the inability to walk 400 meters compared to those individuals that were randomized to physical activity here. So the physical activity resulted in an 18% improvement in the prevention of the onset of the development of mobility disability. So exercise increases muscle mass, increases muscle strength. It will improve muscle power, delay fatigue, and actually reduce the onset of major mobility disability. When we look at pharmacological interventions in sarcopenia, there are a number of different molecules that have been evaluated. These are data, the first data looking at the first anabolic steroid testosterone by injection here. This was in young, healthy volunteers. This study was done back in the 1990s by Shelley Basinin. The interesting thing here is if you give pretty high doses of testosterone and anthate, this is 600 milligrams by injection weekly to young, healthy males, you can see that you can increase fat-free mass by DEXA, muscle mass by triceps area, quadriceps area. Muscle strength also improves by testosterone alone. But interestingly enough, if you combine that with exercise plus testosterone therapy, again, remember, this was in young individuals, you see this synergistic effect of testosterone, high-dose testosterone with resistance training exercise in young individuals increases more muscle mass and muscle strength here. And this really set the pharma industry on a path here, because they started to try to develop non-steroidal SARMs with the idea that they would have similar effects as the steroidal SARMs here. This is the data on testosterone in healthy older men showing a dose response effect here. These are lower doses that were used in the young men, 125 and 300 milligrams per day by injection. But again, also showing improvements in leg muscle mass, strength, muscle power, and leg press fatigability here. Yet when the large randomized phase 3 trial was done using topical administration of testosterone, this is 5 grams of androgel per day in older men that at baseline had low circulating testosterone concentration. So the study here was to take men with low circulating testosterone and bring them back up to physiological levels of testosterone. We look at the primary outcome here. There's really no difference, at least by the primary outcome here, in individuals that were randomized to a placebo gel versus topical androgel here over the course of a 1-year period. So in the phase 3 trial, topical testosterone in hypogonadal men did not improve physical performance here. There have been some data looking now at the non-steroidal SARMs. These have less off-target effects. This was a trial looking at the non-steroidal SARM, enobosarm, or it's also called Osterine by GTX, in patients with cancer cachexia. They had to have had greater than a 2% weight loss in the last 6 months. They either got 1 or 3 milligrams of enobosarm for 113 days, and the primary endpoint was the change in lean body mass by DEXA. And you can see here that there was a significant effect on lean body mass by the enobosarm here at 1 and 3 milligrams of dose. And when they measured stair climbing power in these individuals, it also improved significantly. However, the positive effects in this phase 2 study did not translate over into a successful phase 3 trial. They tried this compound in non-small cell lung cancer with a co-primary endpoint of appendicular lean mass and stair climb performance, and they failed to meet their co-primary endpoint in 2 pivotal phase 3 trials, Power 1 and Power 2. Although in both studies, the compound did consistently increase lean mass, and it was interesting that a greater than a 0.25 kilogram increase in lean mass was associated with a significant improvement in stair climb power. However, this lack of meeting the co-primary endpoint in both phase 3 trials actually stopped this program on enobosarm by GTX several years ago now. If we look at the data on myostatin, this is the GDF8 protein. As I mentioned, it's a negative regulator of muscle mass, binds to the activin D receptor, activates SMAD signaling. And this activation of the SMAD complex does induce and is a transcriptional regulator of several of the atrophy genes in skeletal muscle, MRF1 and some of the other atrogenes that are associated with muscle atrophy in muscle. We know that in genetic breeds of dogs and cattle, the deletion of this myostatin gene, and in humans, this deletion of this myostatin gene results in a well-described hypermuscularity. I think this is the knockout mice here. You can see that from Sage and Lee, looking at the lifelong knockout of GDF8 here. This is the muscle size and cross-sectional area of the individual myofibers here in the wild type versus the GDF8 knockouts. It's very, very, very striking. You can tell which animals are the knockouts here. And if you use the probably furthest along program using modulating myostatin has been the program looking at bimagrumab by Novartis. This was a compound that they developed. So this is an activin 2B ligand trap here. If you give bimagrumab by infusion, you see a very significant increase in thigh muscle volume. This was in older adults here compared to placebo, about an 8% increase in thigh muscle volume by MRI, significant increase in total body lean mass by, again, DEXA here. So really robust increases in muscle mass with this activin receptor ligand trap here. But when you look statistically at the changes in 6-minute walk distance in older adults that receive bimagrumab, there's really no difference in the change in 6-minute walk difference from baseline to placebo here. Interestingly enough, they did some secondary analyses on these data where they looked at individuals that were walked slowly at baseline, and in individuals that walked slowly at baseline, there did seem to be a significant impact of the bimagrumab antibody on improvements in their walking speed here compared to individuals that were fast walkers at baseline. However, when they went and did a larger phase 2 study, recruiting only people that had a slow walking distance at baseline for the trial, they again saw no significant improvement in 6-minute walk distance with antibody administration in those individuals. They also looked at this in COPD, people with chronic obstructive lung disease. And again, bimagrumab did increase thigh muscle volume. So it is an anabolic agent. It does increase muscle mass, but there were no effects on physical performance. We've done similar things. There's another monoclonal, a humanized monoclonal antibody to myostatin that was developed by Regeneron 1033. Again, this was a study we did in older adults. It significantly increases MRI thigh muscle volume here. These were individuals that got placebo or the Regeneron 1033 antibody. One group was sedentary. We also had a group that got resistance training exercise. We did not see any significant difference between the individuals that got antibody alone compared to combination with resistance training exercise. And when we looked at the changes in strength, it was a lot more complex here and very hard to tease out the effects of the antibody with or without resistance training alone. We certainly weren't powered to see differences in strength with this. This was a small phase 2 study here, but we would like to pursue this to see whether there are synergistic effects with the resistance training intervention alone. I mean, I think there's a number of reasons why we to date have not had an approved a pharmacologic approved indication for sarcopenia. I mean, some of the reasons I think that are important here are that the SARMs and some of the myostatin antagonists that have been evaluated to date have been relatively weak androgens, and the doses by choice that they've used have been relatively low. I think we've tried to do really good studies in this area, but I think some of the trials, some of the multi-center trials have suffered from poor trial design issues, either relatively small sample sizes, poor execution, inappropriate selection of the target population, in some cases, poorly crafted indications. this definition of sarcopenia we've struggled with, and it's changed over time. And I think that's been problematic. The larger trials that have been done have not always included an exercise or behavioral intervention. And there's some idea that simply making the muscles larger may not be enough to overcome some of the age-related deficits we see in strength and motor function and physical functioning. And there may be a need to add an appropriate exercise or behavioral intervention to these trials, whether there's some permissive level of exercise that's required. I don't think we really quite know yet. And I think we've been plagued with a number of regulatory issues from the regulators, FDA and European Medicines Agency. The regulatory bar for trials in sarcopenia is relatively high. As I kind of told you, the lack of consensus on a definition and link to hard clinical endpoints has been a problem, although there has been recent excellent progress, and that's continuing. There have been some issues with endpoint selection. The primary outcomes have varied. Failure to demonstrate how a patient lives, feels, or functions. I think we do need a validated patient-reported outcome in sarcopenia that we can use, and that can be, we can adequately power trials with this as either primary or co-primary endpoint. I just want to speak very briefly that some of the really novel compounds that also may be important to look at. These are preclinical data looking at the selective skeletal troponin activators, showing that this compound that activates and increases the sensitivity of the troponin, the muscle troponins to calcium, can actually increase the amount of force generation that is developed relative to the frequency of stimulation. These are preclinical models here, so you can increase force output and specific tension here without increasing muscle mass and without increasing the maximal tetanic frequency here. And these may be important targets in sarcopenia. Also, some of the therapeutic targets that are targeting mitochondrial function. This is preclinical data from Johan Auer's group looking at urolithin A, which stabilizes skeletal muscle mitochondria through mitophagy pathways, at least preclinically can increase grip strength, running distance, and nicotinamide riboside, which has been around a little bit longer, can also in preclinical studies increase running distance and grip strength. The studies on nicotinamide riboside, the clinical studies have been equivocal. Some have been positive, some have been negative. The studies on urolithin A have tended to be more positive. There have also been some studies looking at mitochondrial transcripts from skeletal muscle biopsies obtained from older subjects that take urolithin A, and those have shown upregulation of some of the mitochondrial transcripts in this area as well. So I think there are some interesting, exciting other target therapies that might be important. There's some work looking at some of the alternative angiotensin pathways, the angiotensin 1-9 signaling pathway. There's a compound called Bio-101 that's being developed by Biophytes, targeting the beneficial arm of the renin-angiotensin system, the angiotensin 1-7, targeting the MAS receptor. We have some phase 2 data now. This was a study that I led that was seriously interrupted by the onset of the pandemic, showing some trend of a dose response in terms of improvement in gait speed at the 350 milligram dose of Bio-101, which activates the MAS receptor. Although I can tell you that we lost a lot of subjects in this phase 2 trial because of the onset of the pandemic. So I'm not sure we can interpret very much about this, but there was at least a trend using this MAS activator in this study. I think I'll skip talking about inflammation because we are running a little bit out of time, and just end with what I think I've tried to tell you about here is really that where we are with our current understanding of sarcopenia, this idea that there probably is a biological and environmental etiology to sarcopenia, review some of the differing approaches towards a definition of this syndrome. And I think there's an emergence of an evidence-based criteria for defining sarcopenia, and then just talk you through some of the exciting interventions that have been in development for sarcopenia, and I think some of the exciting areas where there still is some potential to develop new and exciting therapies in this space. So I want to thank you for your attendance. I know this is always hard to do on Zoom, but I'm happy to take any questions, and thank you for joining us today. I really appreciate the invitation.
Thank you, Roger. That was really interesting. So now the discussion is open for questions. Please raise their hands or just ask your questions. Felipe?
Yep. Thank you very much, Roger. It was very, very interesting to know what's going on in this area. And, thinking about, you're kind of focusing muscle. Of course, the muscle is innervated. And kind of considering that muscle mass is so sensitive to innervation, we know that, right? And what do you think about, and considering also that kind of myelinated fiber, net conduction velocity, everything goes down along aging. What do you think is the contribution of the nervous system, a kind of innervation versus muscle, and associated to that, that could explain this uncoupling between the muscle mass and muscle strength? What do you think about, this other area that is a nervous system in sarcopenia?
Yes, nice to see you, Felipe, and thank you. That's an excellent question. I mean, I think the first thing to remember is the best epidemiological data we have shows that muscle mass is probably lost at about 0.5% per year. Strength is lost at about 1% per year. So there has to be uncoupling between those two things. So, but how much that is from, impairments in sort of cortical activation and descending motor pathways, or how much of that is related to activation or myelination or nerve conduction velocity versus what's happening once the action potential reaches the muscle, and there's the whole process of excitation contraction coupling. I think it's hard to I will say is that I think there's a lot of opportunity to understand, where you could target therapies. That's why I use the troponin activators as just one example that's in the literature and a little bit further along, and something I know a little bit about, but it's targeting muscle function without actually really causing any increase in muscle mass. So I think there's a lot of opportunities for looking at lots of pathways along within both the central and peripheral nervous system. To sort of think about targets.
Yeah, thank you.
Any other question for the audience? Raise your hands, or if I don't see you, just speak. Marcelo?
Hi, thank you very much, Roger, for your brilliant presentation. I'm very interested in the field. So my question is in regards to younger population. We know that some studies have reported that the prevalence of a suboptimal muscle mass in younger population, let's say 20 to 38, 39 years of age, is quite high. So I was wondering whether we could focus more in that younger population and the treatment of the suboptimal muscle mass development, instead of having this tremendous effort to reduce sarcopenia in perhaps people that already have it many decades before.
Yeah, I think you make those are really important observations. We know that people start to lose muscle mass and strength, and that happens earlier in life. And there are probably even some very, very important epigenetic determinants of who reaches, peak muscle mass and peak muscle strength and peak bone mass early in life. So there are lifelong contributors probably to this syndrome. What I would say about that is, I think if we want to take that approach, and that might be wise, I think when we're taking sort of a life course approach, we want to probably think about preventive strategies first, because those are generally going to be more safe for people to sort of be, trying to participate in throughout their lives. So whether it's appropriate nutritional interventions or appropriate exercise therapies or physical activities interventions, to think about pharmacologic treatments that you might start to prevent something that isn't even really occurring until someone's 70 or 80 years old. I think that may be very challenging. Both, the safety of a compound like that would have to be extremely, extremely high. And I would say, when we get to the point of, talking to regulators about these things, these are the kind of questions they're going to ask. So I think I acknowledge that we need to do better earlier, but we also, I think maybe for some treatments have to focus on people that already have this syndrome and this problem now. And I think those are the people that are going to be more amenable. We're going to be able to eventually develop treatments for first. So I think we have to approach this a couple of different ways, but it's a very important point. These are life course events and phenomena that don't just happen, when somebody turns 60 or 70 years old.
Thank you.
Any other questions in the audience? Please, don't be shy. Very well. People think I have a couple of questions myself. Oh, Marcelo, please go ahead.
Sorry, I'm gonna do a second question. It's in regards the muscle quality, because we have seen changes in muscle strength and muscle mass, and which are very obvious in relation to age. But there is a lot of studies out there showing a marked replacement of muscle mass by fibrosis in intermuscular adipose tissue. So this fibrofatty replacement of muscle mass is also part of the syndrome, but it's not included in any consensus or cutoff point or whatever. So based on this argument and the response to this pharmacological treatment, I was wondering whether the presence of this fibrofatty tissues is also part of that resistance to the treatment, or maybe is related to the effect or the lack of effect on strength.
I don't know. I think that's an important point. I don't know the answer to that. I think clearly you're correct that in addition to the very superficial, if you will, decline in muscle mass or cross-sectional area, there are more subtle changes within the existing muscles that occur, and there is more of a shift to more intramyocellular lipid deposition in fibers with aging, and probably there are corresponding changes to some of the bioactive lipid signaling molecules that occur, like the ceramides, like some of the fatty acylcarnitines that are in muscle that have effects, probably do have effects, we know, on some of the anabolic signaling pathways and probably some of the proteolytic pathways in muscle. That could in part influence some of the lack of sensitivity to some promyogenic agents. So I think from a target standpoint, those could be important pathways to target. Whether they should be included in this more objective definition of sarcopenia, I'm not sure, because we just don't have data in large epidemiological cohorts of how much they contribute. So until we have that data, it's going to be hard. But those are important points, and there are subtle changes in muscle, and they could be important targets for therapies for sure, either antifibrotics or compounds that affect bioactive lipids, ceramides, things like that in muscle.
Yeah, but my question was targeting the presence of adipose tissue within the muscle. So the fatty strips between muscle fibers and the pro-inflammatory effect of this adipose tissue. on
Yeah, I mean, I don't know too much. I mean, there bound to be some data soon on the GLP-1 agonists and what you know, people lose weight, they lose fat. I don't know what it does to muscle function, but that may be very interesting. So yeah.
Any other questions? Well, I would like to ask about, just along the same lines of Marcelo was asking about sarcopenia. Obesity seems to be a new emerging field. If you can give us any thoughts about it.
Yeah, you know, we have struggled to define sarcopenia, so I've always been sort of a little leery or hesitant to try to sort of try to define what I think about as sarcopenic obesity. But of course, the prevalence of overweight and obesity is very, very high among individuals over the age of 60. So of course, many people that have sarcopenia, however you define it, are also going to be by definition obese. And at the molecular level, we do know that there are interactions and important interactions between adipose tissue and skeletal muscle myocytes. We have some really nice data in our lab. I didn't share them today that are in review now, showing that exosomes that come from adipose tissue of older mice actually have microRNA that are potent activators of myostatin in muscle. So there may be some important crosstalk between, and it appears that the circulating exosomes are largely come from adipocytes. It appears, because if you knock them down, you don't get as many exosomes in the serum. But anyway, I think there's a lot of important crosstalk between between fat and skeletal muscle, so that, you know, increases in adipose tissue, whether it's extracellular vesicles, there's also an inflammatory response that happens in excess adiposity, have effects on muscle. So I think there's important molecular interactions as well.
Perfect, thank you. And I have a question. In the beginning, you show that senescence is increased in the muscle. And which cells are the stem cells that are senescent, the fibroblasts?
Yeah, so you know, those data are really just on serum, on measures of 27 proteins that we have shown to be that Nathan actually showed to be secreted by senescent cells. We measured them in the plasma. They've done some studies looking at senescence in muscle, and there looks to be some subtypes of myocytes that are that I think are P21 positive, and also some other cell types in muscle. You know, not all muscle groups don't have all just muscle cells in them, but there are FAPs, fibroadipogenic cells, that also seem to be senescence in the muscles of older animals. They published a really nice paper in Nature Medicine within the last year, trying to look at the subpopulations of senescent cells in muscle. And not all muscle cells have senescence, but there are these subpopulations. So I think what we measured in the plasma in this sort of epidemiological study is a little different. We don't know what cells those are coming from, you know, and I think that's always the struggle there, right? But we did find it was interesting that some of them were related to strength and some of them were related to physical performance. So,
right. Thank you. There is any other question from the audience? No, I guess that's. I have just one last question.
Sure.
Are all the muscle affected the same?
With aging?
With sarcopenia, yeah. I mean,
yeah. It does seem to be that their upper extremity muscles lose muscle mass a little bit more from the upper extremity than the lower extremity, probably because even people who are very sedentary, they're still doing some weight-bearing activity. It's probably because of differences in activity, but even the lower extremity muscles are affected.
Yeah, right. Well, if there is no more questions, thank you, Roger, for amazing talk.
Thank you, Cesar and the entire group. I really enjoyed it, and I hope I get back down to Santiago someday. So thank you very much.
Definitely, we should bring you soon.
Okay.
Thank you.